Hey NCS podcast listeners, this is your host Fawaz Al-Mufti from Westchester Medical Center, New York Medical College. Over the last 20 years, the inclusion of advanced practice providers in critical care departments has allowed them to emerge as invaluable, ever-present team members, crucial to the continuity of care and a stabilizing force for intensive care units. As such, the integration, advancement, and education of advanced practice providers is essential to maintain a high-functioning neuro-ICU. We're excited to collaborate with the NCS Advanced Practice Provider Leadership Section to launch the NCS Advanced Practice Provider podcast miniseries. Over the course of 5 episodes, we will discuss a variety of topics ranging from APP utilization and staffing models to billing practices, and hopefully present ways by which intensivists and forward-thinking advanced practice providers can work together to optimize the daily functioning of the neurocritical care units. I hope you enjoy this episode.
So welcome to the APP Billing Podcast. I wanted to introduce our guest, David Carpenter. Mr. Carpenter is a physician assistant working at Emory University in the Department of Critical Care Medicine. He has been practicing as a PA for 20 years and has contributed to the field through multiple presentations, publications, and textbook chapters, many of which focus on quantifying and optimizing APP productivity in the critical care environment. He is a fellow of the American Academy of Physician Assistants, as well as the Society of Critical Care Medicine. He is the past chair of the Coding and Billing Committee for SCCM and the current chair of the APP Committee for SCCM. In addition, he is co-director of Quality and Patient Safety at the Emory Critical Care Center at Emory Healthcare. We're very fortunate to have Mr. Carpenter here with us today to discuss the role of APP billing in critical care. Welcome, Mr. Carpenter.
All right. Thanks, Chris. It's great to be here.
Thanks for coming. So I guess the first start for billing tends to be sort of contentious. You either love it or hate it. I guess a general entry point is how did you find your way into billing and coding domain, and what do you enjoy about it?
It's kind of an interesting story. It was, I think, kind of self-defense. The first job I had out of PA school was in a subspecialty that was kind of had a very interesting management structure. And, one of the things they're like, well, we're consultants, so everything's a consult. So everything was billed out as a new consult. And after about 2 years, I left and went to a practice that had a more traditional billing or management style. And, they had coders and a manager and all that. And they started sitting me down and kind of going through this. And I'm like, wow, there's a lot I don't know about billing and coding. And at the time, AAPA had a coding and billing course that they did usually at the post APA conference. And so I went to that and kind of learned a bit. And then, a little bit of knowledge kind of makes you an expert in this. And so then I started giving talks. And when I moved to critical care, I kind of identified that critical care billing is actually fairly unique compared to other types of billing. And so, I had the basic knowledge to kind of understand the rules. And so I started reading up, and after, a little while, they started asking me to kind of give talks and, work within the group to kind of improve billing. And that's kind of how I got into it.
Great. So I guess to bring it up to the present moment, where do you practice now, and what is your institution's APP billing practices, and what do they look like? And do you think that that's representative of the current landscape of APP billing nationally?
I definitely don't think it's representative. I do a fair amount of consulting, and I'm continuously amazed by the, amount of groups that don't bill for APPs at all, especially on the inpatient side, that they're worried that it will take away from physician billing. They're worried that, they don't know how to do it. And I think it's definitely the way we work isn't representative. But I'll also say that even within our own institution, I don't know if it's completely representative. We have pockets where, that they don't bill for their APP services where they should. So currently I'm a PA in the surgical transplant ICU. Although in the times of COVID, I've been moving around quite a bit to our various COVID ICUs. And so that's 2/3 of my job. And then 1/3 of my job, originally about probably 6 years ago, they carved out 1/3 of my job doing documentation and billing education And then they kind of added the co-director for quality and patient safety about a year and a half ago to that. There's me on the APP side, and then we have a physician on the MD side that are their co-directors and kind of work, within the department to kind of work on different quality initiatives. We have 160 APPs in the Emory Critical Care Center now. We have 1,000 at Emory, and like I said, the big issue with critical care APP billing aside, and everybody kind of asks like, what's our secret sauce? And utilizing APPs to the best of their ability is part of it. We have a 24/7 APP model with physician presence during the day, and that generally works pretty well. The real issue is that we account for APP time continuously, and there's an expectation. So everybody has to demonstrate their worth. So we know, because now we have over 10 years worth of data, that we provide. So if you take an APP salary, we bring in about 130 to 140% of that salary in revenue. And so whenever we have to get, so other places like, well, we need a new APP. Well, how are you going to pay for it? When we say we need a new APP, they're like, okay, you need two? We got, and we've also done a lot of modeling that we've published in SCCM and other places that, to figure out there's a response curve, I guess is probably the best way to say it, is as you add APPs, your billing actually gets better, but at some point you kind of saturate the amount of billing you can do, and then it kind of tails off. And so we use that modeling to staff our units. So, we also benefit, we have, in our center, we have 3 biostatisticians or statisticians that if I go to somebody and say, hey, we wanted to figure out this model, I got people that can do that. And that's actually, incredibly helpful.
I'm quite impressed by that statistic of 140%. I guess I'm impressed, not surprised. I think a lot of people would agree that APPs contribute a lot to their units. And I think what's most salient about that is that it provides some sort of metric to actually demonstrate, instead of this abstract idea of, yeah, we know they do something on the unit, but here's an actual number that demonstrates their worth and their value. So I guess in terms of thinking of billing alongside of a physician, it sounds like 24/7 and daytime kind of parallel with your APPs on the unit. Can you touch upon shared versus consecutive billing practices between the APP and the attending physician?
Sure. So we use to differentiate, the shared billing is in non-critical care. So some other kind of evaluation management, where both the APP and the physician see the patient. The APP writes the entirety of the history, physical exam plan, and then the physician documents in one portion of those 3 things, usually the plan. So if I see a patient, and this is for Medicare only, if I see the patient, or Medicare and Medicaid, if I see the patient and do that and then put my bill in, I get 85% of the physician reimbursement. If the physician also sees that and does their part, you bill into the physician at 100%. So that's kind of how we do shared billing. Not all of our units do that, to be honest. That it's all depends on kind of how much billing the physicians already have. If there's a resident service that's working with, usually we'll have a separate resident and APP service within the same unit, in about probably 6 of our units, 6 of our 14 ICUs. In that case, usually the resident service generates enough billing that the physician doesn't want to do more billing. And the rest, we kind of use the shared billing model. For critical care, the consecutive billing model works pretty well. And the only thing is just to document that you weren't billing critical care on the same patient at the same time. And part of that also is communication between the providers. Like if we both go into a room to respond to an emergency, you'll like, let's say we go in, there's somebody codes, I'm running the code, there's a resident in there doing CPR, the attending comes in. At the end, I'm going to do critical care time for running the code. And he goes, okay, I'll bill CPR for the resident. If the resident, if he's running the code, or there's a fellow running the code and he's supervising and I'm just in there, helping, then we actually have a documentation that it's called, we have actually 3 ways of documenting APP time that's non-billable, and we just kind of bill it under one of those times. So it actually works pretty well. And and you always kind of just discuss, like, the other thing is to discuss, there's a lot of, as the patient transitions from being critically ill to not critically ill, to make sure you're still on the same sheet of music. There's a lot of copy forward with notes, so I'll say, hey, I'm going to bill this patient as E&M today. I don't think he's critically ill. And they're like, oh yeah, that's fine. That's what I was going to do. Or sometimes we'll talk about it. And then we'll go through, like, okay, what makes this patient, we'll spend a minute going through what makes this patient critically ill. And in the end, we'll say, okay, they're critically ill, or okay, they're not. But it looks bad when that's one of my other jobs is, every week or so, I get about 5 or 6 charts where one APP is billed one, either critical care or non-critical care, and the attending is billed the other.
Mm-hmm.
And the coders say, like, we can't figure out which one's right. And so that goes to me, and then I just look in the chart and say, okay, somebody met there, one of them is right. So
I think that touches upon sort of the collaboration between our physician colleagues and APPs in terms of billing. If you subdivide the APP group, from your experience, is there a difference between PA and NP billing practices, both theoretical and observed?
No, I mean, not on the inpatient side, and actually really anymore not on the outpatient side. The issues that we initially, probably this goes back about 12 years, is the initiative more on the scope of practice. So the PA scope of practice is the same as the physician in Georgia. The NP scope of practice is not as well defined. There's basically, like, what the state of Georgia nursing board has said, well, it's up to the NP to figure out if we're within scope of practice. When we started the critical care center 12, 13 years ago, the director at the time made a decision that only acute care nurse practitioners were in the scope of practice for the ICU. And that's kind of where we've been for that period of time. So we don't hire non-acute care nurse practitioners. Every once in a while, there's a lot of question in Georgia about age-specific care. So every once in a while, we'll get somebody under 18 in the adult ICU. And we have at Emory, we only see adult patients as a separate peds hospital across the street. And then usually it's like, if they feel comfortable seeing somebody under 18, there's one ruling that basically says it's like 13 and above, and there's one that's 18 and above. And so some of them will say, I don't feel comfortable. And then we're like, fine, we'll just have a PA or a resident see the patient. But that's kind of the only, is more the scope as opposed to the, as opposed to the billing per se.
Sure. In what ways does APP billing reflect productivity? You had mentioned there's this billable services, and then there's this group of things that you're billing for that are not billable. And in what ways do you think APP contributions are invisible to abstracted data? So where's the opportunity to see more of the ways that we contribute?
So I think that it's a big problem in shared billing, and it really depends on, because we control the front end on our billing. I can see the APP contribution in shared billing, but in places where you don't control the front end, it's very difficult to see what the APP contribution is to shared billing. Ideally, and I think even at the Medicare level, they don't have a good idea of which of these claims are shared billing and which is not. In the outpatient setting, like incident 2 is a humongous problem. I would guess that probably, from what I've seen when I've done consulting, probably 70% or 60% of incident 2 is done incorrectly. I have places like, well, we just built all of our encounters in the outpatient incident 2, so we don't have to worry about it, which is, just kind of an invitation to get audited. So when we kind of started this, and we published on this probably about 10 years ago, we came up with this concept called patient care time. And what it recognizes is that APPs do a lot of things that are necessary to take care of that patient, but aren't billable. So in critical care, if the patient's not able to make a decision, talking with the family about, treatment decisions and goals of care is billable. If the patient's decisional, then it's not. And like, if, it's always, well, can you talk to my fourth cousin Donald, who lives in New York and is a podiatrist, about this? And you're like, sure. So that's not like billable time, but it's still not, somebody has to do it. And now in the time of COVID, when we don't have visitors, this updating the family has gotten more important. And, if you had one physician covering 20, patients, that's, you spend 10 hours on the phone just updating families. If you've got it split among 4 APPs or 3 APPs, it becomes a lot easier. So what we have is we have patient seen time, patient not seen time, and PA-NP mentoring. And the PA-NP mentoring kind of represents the fact that if you have somebody on orientation, it makes you less efficient. And so we didn't want to penalize APPs that are, training the new APPs. So that's what we kind of came up with. And so our metric is the expectation is you spend 75% of your time in patient care. So, say on a 12-hour shift, it's not unreasonable that we're going to pay you for 9 hours of work. You're gonna use the bathroom, you're gonna eat lunch, you're gonna have some other things. So that kind of consumes that other 3 hours. So every month, everybody gets a report. Here's your patient care time. If you're consistently under 75%, then your lead has a chat with you. And so patient seen is stuff that you're doing for direct patient care. Like let's say we're rounding and the attending is taking the rounding time as their billable time, then I would just put patient seen for that time. If I go in and watch a resident, do a procedure just to make sure nothing dangerous is happening, but I'm not actually doing the procedure, I would bill that as patient seen time. Patient not seen time is kind of other, like if you had to go to a meeting or like sign out, only one side can take the time on sign out. So usually the gaining 18 takes the time on sign out, and I just put patient not seen for my sign out in the evening. So that's kind of how we do it. And then, like I said, we track it. And now we have data going back 10 years. And every, couple months we look through. One of my other jobs is look through and say, hey, here's your 6 people that are sitting at the bottom of the list that aren't really showing their worth. And that kind of goes out to the leads and they have a little talk with them.
So it seems like billing is pretty well seated in your establishment right now. And it may be unfamiliar to some people. I guess one question that I have is, how do you initially onboard for where PAs and NP school don't traditionally teach about billing practices, or maybe touch upon it briefly? How do you take a new hire, someone either with or without professional experience, and get them up to speed in terms of your billing practices? And then how do you continue to refine those billing skills over time?
I think part of it's good because it's so kind of ingrained in the DNA of the center that people talk about it all the time. So I do like quarterly now Zoom calls that people can get on, and then probably once a year there's like a mandatory kind of like update just to make sure everybody's on the same page. As the new APPs come on, the coding educator does like a 1-hour session with them that goes over billing and how to use the computer program that we do to put in the bills. So they kind of get that up front, and then their lead works with them while they're in orientation. And if they have questions, sometimes they'll call me and say, hey, this person doesn't seem to be getting it. Can you talk with them and sit down? And we usually work it out that way. And then, like I said, we watch people that are having billing challenges and then try to figure out, and sometimes it's like really simple. It's like, why aren't you billing? And there's like, oh, well, they told me that I couldn't bill. So, it's always the weird they who is never really identified. They told me I couldn't identify or they couldn't bill when the doctor was here. And they're like, no, that's not true. And they're like, oh, so there's every once in a while you have to go around and stomp out some rumor, stuff like that.
Are there more examples of common errors or missed opportunities in terms of APP billing that is just kind of folklore and that could easily be dispelled?
I think the biggest one is, for critical care is if the physician bills, then the APP can't, which, it's clearly allowed in the Medicare claims law. in the Medicare clear, sorry, it's clearly allowed in the Medicare claims manual. The interesting one I get into is somehow that if APPs bill, then that will affect the income of the physicians. So the physicians don't want them to bill because that affects their income. What I usually demonstrate when we did our original publication, when we, and this is one of the reasons we kind of go with this patient care time as opposed to billing. I think anytime you say you have to bill more, you run the risk of, if you bill more, then Medicare comes around and says, well, is this, are you trying to get people to fraudulently bill? So we very clearly, we clearly tell people, I don't want you to bill more, I want you to bill correctly. But if you look at our original article, as the patient care time increased to goal, the billing time also increased to goal, but then the attending billing also increased. And I think it was I don't have a good explanation for it, except for, I think when everybody's talking about billing, people start to realize that they're not billing for what they do. And especially in critical care, I tell people to kind of work backwards. Is you came in, at 7 in the morning and you're leaving at 7 at night. And if you worked all day and you like barely had a chance to use the bathroom or eat, there's 11 and a half hours of billing in there. So if you're billing for 5.5 hours, you're missing 6 hours of billing. So you need to properly account for their time. And people kind of like, well, that felt like 60 minutes. And, what they don't realize, like, if you say, well, it takes me 10 minutes to put in a central line. Well, you got to get permission. You got to go get the nurse. The nurse has to set up. You got to go find all the stuff. You got to get the x-ray, so when all that gets done, it's probably more like 45 minutes or an hour. And that doesn't change the billing, but it kind of helps you account for your time. And the same way, if you spent the last 3 hours in the room with the patient that's critically ill, just kind of continuously resuscitating that patient, there's 3 hours of billing there. And don't feel bad about putting 180 minutes down, because that's what it took.
In terms of the process of documenting, I think about some colleagues I worked with in the past who basically at the end of the week, they get a stack of all their papers and they go back and do all their billing at one point. And to some extent, that seems kind of cumbersome, where you're spending hours going back and billing for the work that you've done. Are there ways that at Emory or in other places that you've seen that that billing is integrated in a streamlined fashion that makes it less cumbersome and you're not spending all of your time or extra time billing for the work that you're doing?
Well, like everything else, we track that and monitor it. There's two daily reports come out. One is the missed bills report. So any patient that doesn't have a bill within 48 hours of their encounter, that comes out and goes to the leads, and then they look and see who saw that patient and ask why there's no bill. We also have a missed documentation report. So if you forget to put a note in or something like that, you get behind. And then there's another check is when the bills go in, for critical care especially, the coders look into the note and make sure the numbers. And so if you have a bill with no note, or a note with no bill, then a different email goes out. So usually that's within about 72 hours. So really what we're encouraging is people to get the bills in on the same day. And just depending on, so a lot of my colleagues, they have the billing program open on the desktop behind the, we use Cerner or, Epic, it doesn't really matter what you're using. And so as they're putting in notes and finalizing their time, they're putting in, bills also. I tend to wait till the end of the day because, I'll addend the notes and change the time. And then it's like 5 minutes at the end of the day where I just sit there and put all, I have, 6 or 7 patients, so it's click, 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 and go down the row and just put the time in. But I think if you do it at least once a day, you're not trying to remember like how many times. The other thing I do is I kind of track, we have like a sheet that has all the patients on it, and I write the time on as I go along, like usually a couple times a day, like, okay, like this morning and before noon, I spent 60 minutes. And then afternoon, like I spent another 40 minutes. So I'll just, it'll be like 60 plus 40 plus central line to remind me to bill for the central line and how much time that took. So I just kind of track it as I go along.
I guess another question with your experience with other facilities, maybe in some of your consulting work, what are the systems that you see that really just aren't working, and what are the benefits of altering these practices? And maybe to restate what you've already said, what do APPs have to gain from changing and really emphasizing billing in their practices?
Well, I think the biggest change is and this took me actually a fair amount of time to conceptualize, is that there's revenue and cost. So in any business model, it's revenue and cost. And so revenue, you want to enhance revenue and you want to cut cost. So if you're not billing, you're a cost, and that cost gets cut. If you're revenue, you want to enhance revenue. And so if you're pulling your weight, then they're going to get more of you. If you're not pulling your weight, they're going to wonder, then you're becoming more of a cost. And so that, I think, is the single biggest thing that, that's the single biggest thing that APP should realize, is that just like physicians, if you're pulling in money, your revenue, and they're gonna work to make sure that they keep you, you're happy, things like that. So I think that's the biggest single reason that APP should be billing. The other part is just visibility. Is once you move over onto that revenue side, you become visible. So about 8 or 9 years ago, I gave a talk to our CFO of our entire healthcare system. And what he wanted to know was, why were APP's revenue at Emory Critical Care, with one exception, were costs everywhere else? And so we broke that, because we track it, we follow it, and we encourage it. Because they're part of our revenue stream. And so, they haven't completely embraced the model, but it's moved a lot more. And we've seen a lot more, APP clinics, like the COVID clinics are almost all APP run. Because we can easily redeploy APPs. It's hard to take like somebody that, internists you could put into like an APP clinic, but usually they're still working. It's some of these other, like ophthalmology is kind of shut down for a while. It's not like you can take an ophthalmologist and put them in a COVID clinic. But the APPs are pretty adaptable. And I think that's the other thing they're realizing. When you look at your mix, if you've got the right amount of APPs, you have a very adaptable workforce.
So it seems like that just being part of the culture and transparency and frequent communication is really important when it comes to billing, especially as far as revenue. If billing is something that happens behind closed doors and you're not aware of the revenue you're generating versus the cost that you are to the system, then it's sort of this abstract idea. But if that's part of the culture and that's communicated and discussed openly and freely, that seems like a good motivator for participation in a billing model. Would you agree?
Yeah, exactly. I mean, I think generally, the communication helps. Like I said, we communicate, and part of it, I think, when we originally did our first, we do these as incentives. So each year we get a couple incentives, and then that goes into your bonus. It was actually one of our very first ones, and the whole point of the incentive is, here's where our patient care time is now. Can we get it to 75%? And everybody hit that. But along the way, it was constantly being reinforced for a whole year that, here's your billing, here's your billing, here's your billing. And so it got people talking about billing and communicating about billing. And I think, and so now when somebody's like, well, and you'll hear people like, my patients weren't very sick today. I didn't have very good billing. And that's the way it is. We don't go looking for more billing, or it'll say, like, sometimes I'll say, look, like, I've got like 6 non-critically ill patients. I'll take the next admission. Part of it is I have 6 not very sick people, so I've got time to go do it. But part of it is I'm looking at like what my billing is, and I'm like, I'm going to go take some more work. So I think the culture and the communication is a key part of it.
So I guess for the listener who maybe is not part of a hospital system or healthcare system that does not have billing quite as prominent in their practice, what would you say for the eager listener who's interested in billing? What is that first step to making a change in the billing and coding practices within their setting?
I mean, I think the first step, I mean, there should be somebody hopefully that understands billing and coding in that organization. There should be a billing. I mean, if they're putting bills in, there should be a billing service. The coders, generally. So I've also got, along the way, I picked up my coding certification. So I'm what's called a certified professional coder. And that I thought that was actually very helpful because it allows me to talk to the coders and speak the same language. Sometimes I'll get this email like, I've been trying to tell them to do this thing and they don't understand. And a lot of times it's like weird little things like in coding world, inpatient billing is all the hospital services and outpatient billing is all the physician services, including the inpatient physician billing. And so they're like, well, this is outpatient billing. And everybody's like, no, I work inpatient. I'm like, no, like it's a different concept. But I think sitting down, and talking with the coders, I'm sure they would love to have a, provider sit down and talk with them and say, how am I doing? What can I do better? And there's like, sometimes there's little things like the order where you put your codes in actually matters. And by doing that the right way, you either improve or you decrease your chance of denials or save them time on the back end having to rearrange your codes to be in the right order. So I think the first step I'd say would sit down with your coders and just talk to them and say, like, how am I doing? Is there anything I can do better?
And then for a clinician or an APP who is interested in developing more of a knowledge base around billing, can you think of any resources that are great to access for this kind of material?
Yeah, the one I kind of like the best that's online, there's one, it's called E&M University. If you just Google E&M University, and it's they've kind of moved to more of a paid model, but there's a lot of the resources that are free. And so if you want to say, it's like if you look up like, okay, this is a mid-level inpatient encounter follow-up, it will actually tell you like, this is what you have to document. And like, it'll say you have to document like this many physical exam findings. And then if you click on physical exam findings, it will show you what those should look like. And then it will give like an example or two at the bottom of, this is the type of encounter that normally would be billed as this. And it does it for all the inpatient and outpatient encounters. For critical care, the article I'd actually probably recommend is it's not free, but it's reasonably priced through SCCM is integrating APPs. And there's a billing section in there that Walter Boyle from WashU and I did that I think is pretty good. Also, if you're a member of SCCM, which I'm going to advocate for, there's a coding and billing corner that comes out on the SCCM connection. And there's archives online that go back quite a ways that talk about critical care billing, talk about different types of billing. And CHEST has a very similar coding connection that is pretty good, and it's pretty available online. I think it's free if you just Google that.
Great, thanks so much. Well, those are many of the questions that our listeners had about billing. Is there anything else that you think that you would really want to reinforce or bring up around the topic?
I just think that the big thing is just kind of what I said is that you should be billing for the work you do. You should know generally how much billing you're doing. And that, communication is the more APPs that we move to the revenue side, the more that people are going to realize that you need to hire more APPs, and the more jobs there'll be for APPs. And part of it, I mean, I've been doing this long enough that I've kind of seen the shift. When I started, it was you got a job as a PA or NP because the physician or the physician group understood how PAs and NPs worked. They were vested in them, they trained, and then kind of along the way, it's, well, my business manager says I should get a PA. They're not necessarily vested, they don't understand the orientation, they may not understand the educational models. They definitely probably don't understand the billing. And so it means we're kind of have to take the lead in making sure that happens. On the PA side, I'll also say AAPA has a fair amount of documentation, and there's a gentleman named Michael Poe, who's, I think, their vice president for reimbursement. If you ever have like a PA specific billing question, you can email Michael and he'll answer you, and the answer will be the correct one. Great.
Well, I want to thank you from the bottom of all of our hearts to taking your time out of probably your very busy schedule. You are certainly a fountain of information, and we have probably only scratched the surface. And so we appreciate the little bit that you've given us this past little time or so. And hopefully we'll be able to have more chats in the future moving forward.
All right. Well, thank you. It's been great.
Thanks so much.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tariq El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Cassie Cronfield, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, John Rosenberg, Jason Siegel, Zachary Threckeld, Teddy Yoon, and Chris Zammit. Our administrative staff and senior producer is Bronnie Rousseau. Music by Mohan Katapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.